afternoon, everyone. It's a pleasure to be with you this afternoon. My name is Miranda Mosley, and I'm the Director of Education for the Kentucky Medical Association. Thank you for taking time out of your busy day to join us for such an important and timely presentation about the clinical considerations of the COVID-19 vaccine for children ages 5 to 11. A few housekeeping items before we begin. This activity has been accredited for CME and no relevant relationships to disclose. To claim CME, a SurveyMonkey evaluation will be sent via email to attendees following today's presentation. CME certificates will be processed in 3 to 5 business days. This event is being conducted as a webinar, and as such, your camera and microphone are disabled. We have some amazing speakers with us today, though, and I encourage you to utilize the chat and Q&A functions in Zoom, and we'll try to answer as many questions as possible at the end of the presentation. Throughout the pandemic, KMA has worked to provide timely educational information for our members and to communicate important messaging to the physician community and the public. This CME opportunity aligns with our public health campaign, Take It From Me, which encourages physicians and patients to receive the COVID-19 vaccine. Listen as we hear now from Louisville pediatrician Dr. Mark Brockman on the importance of getting vaccinated.
I've had many cases of patients where they have contracted COVID and have disrupted their school life, their social life, their sports life, and their family life, especially where they can't be around those family members for an extended period of time that maybe were their support system.
We hope that you'll consider the KMA website to learn more about our vaccine campaign and to hear from other physicians and encouraging patients to take it from them and to get the vaccine. We are honored today to have 2 distinguished speakers with us to talk about the COVID-19 vaccine for children. Dr. Rachel Gorwitz serves as the Associate Director for Epidemiologic Science at the Centers for Disease Control and Prevention, National Center for Immunization and Respiratory Diseases, Division of Bacterial Diseases. Dr. Gorwitz is currently supporting the CDC COVID-19 Vaccine Task Force as Deputy Chief Medical Officer. She is a board-certified pediatrician with expertise in infectious disease epidemiology. Chris Duggar leads the Centers for Disease Control and Prevention's Vaccine Distribution, Awardee, and Partner Support section for the COVID-19 response in the Vaccine Task Force. Chris has served in a number of roles with the CDC, including the National Center for Immunization and Respiratory Diseases Influenza Division, Acting Branch Chief for Global Health Country Strategy and Implementation Branch. As a graduate of the Presidential Management Fellowship, Chris has worked not only with CDC, but also the Food and Drug Administration, HHS, DoD, and collaborated with multiple government partners. I'm so excited to welcome them today. And with that, I'll turn things over to Dr. Gorwitz.
Thank you so much. Is the sound okay?
You sound good.
Great. All right. Well, I'm really happy to have an opportunity to talk to you today about vaccinating kids for COVID-19. Let's see here. So this is an outline of my presentation for today. And I'll start by reviewing the epidemiology and burden of COVID-19 in children and adolescents. This figure shows incident cases by age group. The light peach line shows incidence in children 12 to 17 years old, and the dark blue line shows incidence in children 5 to 11 years old. In the recent peak in September 2021, which was associated with the Delta variant, among all age groups, incidence was highest among children aged 12 to 17 years, followed by children aged 5 to 11 years. Throughout the course of the pandemic, there have been more than 2.6 million cases in the 12 to 17 year age group, and more than 2 million cases in the 5 to 11 year age group in the United States. This slide shows the proportion of cases by age group over time. In recent weeks, children and adolescents aged 5 through 17 years have made up nearly 20% of all COVID-19 cases in the United States. To put the burden of COVID-19 hospitalization among children into context, comparisons were made between cumulative hospitalizations for COVID-19 in 2020-2021 and for influenza in 2020-2021 and the previous 3 influenza seasons. Among children aged 5 to 11 years, the hospitalization rate for COVID-19 in 2020-2021, which is shown in the yellow line, was similar to that for influenza in the previous 3 seasons, which are shown in blue, green, and red. In contrast, in the 2020-2021 influenza season, there were almost no influenza hospitalizations in this age group, likely as a result of the widespread mitigation measures that were in place. Had these mitigation measures not been in place, hospitalization rates for COVID would likely have been even higher. So this is a similar slide showing cumulative hospitalization rates for COVID-19 and influenza among children ages 12 to 17 years. Among this age group, even despite mitigation measures being in place, hospitalization rates for COVID-19 in 2020-2021 were substantially higher than those for influenza in the previous 3 influenza seasons. And this slide shows COVID-19 deaths among children by age. Since the beginning of the pandemic, there have been at least 94 COVID-19 deaths among children 5 to 11 years old in the United States. While this number is low in comparison to adults, this would place COVID-19 among the top 10 causes of death in this age group. Among children aged 12 to 17 years, there have been at least 253 COVID-19 deaths. While COVID-19 cases can be severe in and of themselves, we also worry about post-COVID conditions, and most notably multisystem inflammatory syndrome, or MIS-C. MIS-C is a severe hyperinflammatory syndrome that occurs 2 to 6 weeks after acute SARS-CoV-2 infection, and it can result in a wide range of manifestations and complications. MIS-C tends to be quite severe, with 60 to 70% of patients requiring intensive care treatment and a case fatality rate of 1 to 2%. Over 5,500 cases of MIS-C have been reported to the national surveillance as of November 1st, with an estimated incidence of 1 MIS-C case in approximately every 3,200 SARS-CoV-2 infections. Incidence of MIS-C is highest among children aged 5 to 11 years, with a median age of 9 years. Furthermore, there are notable racial and ethnic disparities in MIS-C incidence, with 61% of reported cases having occurred in children who are Hispanic, Latino, or Black non-Hispanic. But beyond MIS-C, additional post-COVID conditions can occur in children. These encompass a wide range of new, returning, or ongoing health problems, including both physical and mental health consequences experienced by patients 4 or more weeks after initial SARS-CoV-2 infection. While few data exist on post-COVID conditions in children, they appear to be less common among children than among adults. Further investigation is needed to better characterize post-COVID conditions among children, but a national survey in the United Kingdom found that 7 to 8% of children with COVID-19 reported continued symptoms more than 12 weeks after their initial diagnosis. Of note, post-COVID conditions in children can occur after both mild and severe cases of COVID-19, as well as after MIS-C. To further put the burden of COVID-19 among children into context, comparisons can be made to morbidity and mortality from other pediatric vaccine preventable diseases before vaccines were widely available for these diseases. For example, this slide shows deaths per year for COVID-19 among children 5 to 11 years old, as compared to deaths from other pediatric vaccine preventable diseases prior to vaccination, with deaths from COVID-19 being more frequent than deaths from these other diseases. Multiple factors impact the transmission of SARS-CoV-2 virus, including presence and type of symptoms of the index case, type and timing of exposure, viral load, and variant. Some studies have reported similar rates of transmission from infected children as from adults, while others have observed lower rates of transmission from infected children compared with adults. However, it's clear that secondary transmission from children, both to other children and to adults, can and does occur in both household and school settings. Furthermore, studies have shown that vaccination decreases transmission. Of course, in addition to direct impacts of infection and illness, there are a number of indirect impacts of the COVID-19 pandemic on children, including worsening of mental or emotional health, widening of existing education gaps, decreased physical activity and increased body mass index, decreased healthcare utilization, decreased routine immunization, an increase in adverse childhood experiences, and loss of caregivers. For example, this slide shows COVID-19 related school closures by state, with over 1.2 million children having been affected. So to summarize the epidemiology and burden of disease among children, children are at least as likely to be infected with SARS-CoV-2 as adults, although infections in children are less likely to be reported as cases. I didn't present the seroprevalence data, but infection-associated seroprevalence in these age groups was close to 40% in September of 2021. Children and adolescents are at risk for severe illness from COVID-19. Among children aged 5 to 11 years, the hospitalization rate is similar to that for pre-pandemic influenza. And among children 12 to 17 years, the hospitalization rate is higher than that for pre-pandemic influenza. Over 5,000 MIS-C cases have been reported, with most cases occurring among children aged 5 to 11 years. And of note, about 30 to 40% of children hospitalized with severe COVID-19, and about 70% of those with MIS-C are previously healthy with no underlying medical conditions. And post-COVID conditions have also been reported in children. We know that secondary transmission occurs in household and school settings. COVID-19 leads to missed school for children and for their classmates. And based on all of this, wide use of an effective vaccine would reduce public health burden of COVID-19 in children and adolescents. So now I'm going to talk about the clinical trial data and risk-benefit assessments for Pfizer-BioNTech COVID-19 vaccination in children. In the trial among children aged 12 to 15 years, efficacy against symptomatic laboratory-confirmed COVID-19 was evaluated by randomizing participants 1-to-1 to vaccine versus placebo, with about 1,000 participants in each arm. Vaccine efficacy was 100%, with 16 cases in the placebo arm and no cases in the vaccine arm. No hospitalizations due to COVID-19 or cases of MIS-C were reported in any trial participants. Immunogenicity was also evaluated through immunobridging to data from 16 to 25-year-old participants in the primary trial, and the geometric mean ratio met the non-inferiority criteria. No serious adverse events occurred that were assessed to be related to the study intervention, and no deaths occurred in any study participants. Local and systemic reactions were common in vaccine recipients, with pain at the injection site, fatigue, and headache being the most common. Similar to adults, reactogenicity was greater after the second dose, but most symptoms resolved in 1 to 2 days. In the RCT among children aged 5 to 11 years, efficacy against symptomatic laboratory-confirmed COVID-19 was evaluated by randomizing participants 2-to-1 to vaccine versus placebo, with about 1,500 participants in the vaccine arm. Vaccine efficacy was 90.9%, with 3 cases occurring in the vaccine arm and 16 cases in the placebo arm. Similar to adolescents, the geometric mean ratio compared to 16 to 25-year-olds met the non-inferiority criteria. In the trial in children aged 5 to 11 years, additional participants were enrolled to assess safety. So the safety data were reviewed from about 3,000 children who received the vaccine. No serious adverse events occurred that were assessed to be related to the study intervention, and no deaths occurred in any study participants. Similar to adults and adolescents, reactogenicity was greater after the second dose, with pain at the injection site, fatigue, and headache being the most commonly reported symptoms. So then within this context of disease burden and the results of the clinical trials, the benefits and potential risks of Pfizer-BioNTech COVID-19 vaccine can be considered in these age groups. The main potential risk to consider with this vaccine is that of vaccine-associated myocarditis, which was recognized as a rare vaccine-associated event, primarily among males aged less than 30 years, during safety surveillance following rollout of mRNA COVID-19 vaccines, which includes both the Pfizer-BioNTech and Moderna vaccines, among adults and adolescents. When this association was recognized, CDC's Advisory Committee on Immunization Practices, or ACIP, met to reevaluate the risks and benefits of these vaccines and determined that the benefits continued to outweigh the risks for both adolescents and adults. To better understand this risk of vaccine-associated myocarditis, it's helpful to look at the epidemiology of myocarditis in the pre-COVID era. As you know, myocarditis can be associated with a variety of different precipitating factors, but most commonly occurs following viral infections. In the pre-COVID era, peak incidence of myocarditis occurs among infants, with a second peak among adolescents and young adults, especially males. This second peak is thought to be associated with hormonal influences on the risk of myocarditis during male puberty. This slide shows the reporting rates of myocarditis per 1 million doses of mRNA vaccines administered for Pfizer and Moderna, broken down by dose number and age group. As of October 6th, among over 300 million doses administered, 935 cases of myocarditis had been reported during the 7-day risk period for vaccine-associated myocarditis. These reporting rates exceeded the background incidence rate after dose 2 for Pfizer among persons 12 to 24 years and after dose 2 of Moderna among persons aged 18 to 29 years. But note that Moderna is not yet authorized among persons under 18 years, and so rates were not calculated in those ages. This is the same analysis restricting to males. The rates are higher among males, but note that this is still a rare event, with 797 cases occurring after almost 170 million vaccine doses. Also note that the peak rate occurs among boys aged 16 to 17 years and is somewhat lower among 12 to 15-year-old boys, which is consistent with the age distribution of myocarditis cases in the pre-COVID era. The anticipated benefits of COVID-19 vaccination among children and adolescents, namely prevention of COVID-19 cases, likely prevention of hospitalizations, MIS-C, deaths, and post-COVID conditions, possible prevention of transmission, and greater confidence in safer return to school and social interactions, can then be weighed against the potential risks, with the most significant potential risk being vaccine-associated myocarditis. This slide summarizes the estimated benefits and risks for adolescents and young adults, with estimates for females on the first 3 lines and estimates for males on the bottom 3 lines. COVID-19 outcomes of cases, hospitalizations, and ICU admissions prevented are shown in columns 2 through 4, and estimated potential cases of myocarditis per 1 million Pfizer-BioNTech doses are shown in the last column in red. You can see that even among males, among whom the risk of vaccine-associated myocarditis is higher, the number of serious COVID-related outcomes averted exceeds the estimated number of vaccine-associated myocarditis cases. But an additional factor to take into account beyond the number of events is severity. While myocarditis in general and myocarditis associated with COVID-19 and MIS-C is often quite severe, the vaccine-associated myocarditis cases have fortunately tended to be self-limited, with the majority of patients hospitalized for short periods and recovering completely with supported therapy and rest. This slide illustrates the balance of benefits and risks among males over a longer period of time, 365 days, with the ratio of benefits in terms of COVID-19 hospitalizations prevented to potential harms in terms of myocarditis becoming even greater over time. Based on COVID-19 epidemiology and vaccine efficacy data, this slide illustrates the estimated benefits in terms of COVID-19 cases, hospitalizations, MIS-C cases, and ICU admissions prevented for every 1 million vaccination in children aged 5 to 11 years. What we know about risk for vaccine-associated myocarditis among children in this age group, 5 to 11 years, is based on surveillance among adolescents and adults who received the 30 microgram dose. No cases of myocarditis occurred among over 3,000 participants in the clinical trial with 5 to 11-year-olds. However, the trial was not powered to assess the incidence of this rare event. However, there's reason to expect that incidence of myocarditis after vaccination among children aged 5 to 11 years will be lower than rates seen in 12 to 15-year-olds. First, rates of myocarditis in the pre-COVID era, as we've seen, are substantially lower in children 5 to 11 versus 12 to 17 years of age. And we expect that the same pattern will hold true for vaccine-associated myocarditis. Second, the dose used in 5 to 11-year-olds is smaller, is a third of the dose used in 12 to 15-year-olds, potentially decreasing the risk of myocarditis. So next, I wanted to say a little bit about what we've learned from surveying parents about COVID-19 vaccination of children, as well as lessons learned from adolescent vaccine implementation. Among parents surveyed, 34 to 57% plan to get their children vaccinated. This proportion varied dramatically based on whether the parents perceived their child to be at risk from COVID-19 and whether or not they themselves were vaccinated. Importantly, among parents of teens who discussed vaccination with their pediatrician, 3/4 of those whose pediatrician recommended vaccination say their child received at least one dose, suggesting that recommendation from the child's healthcare provider can strongly influence a parent's decision to get their child vaccinated. In a survey of 1,000 US parents of children aged 5 to 11 years in September 2021, 57% of parents said that they would definitely or probably get their child vaccinated. Among those parents who did not indicate that they would definitely get their child vaccinated, safety concerns were predominant reasons selected by parents to explain their hesitancy. We can glean some insights into possible inequities by examining COVID-19 vaccination coverage among adolescents 4 months after ACIP recommendations for this age group. These are results from the National Immunization Survey looking at COVID-19 vaccine receipt and intent among parents of adolescents aged 13 to 17 years in September 2021. The dark blue represents parents of adolescents who had already received the COVID-19 vaccine. The royal blue is parents that definitely plan to have their adolescent vaccinated. The light blue is parents who were undecided, and the orange is parents who said that they probably or definitely would not get their adolescent vaccinated. The first thing that I'd like to point out is that 9.2% of parents stated they definitely planned to get their adolescent vaccinated, but hadn't yet. This group represents unactualized vaccinations, which could represent barriers related to access. This is substantially higher than the proportion of this group for adults, which is 2.2%. When we look at this by race ethnicity, we see that this proportion is highest at nearly 20% among Black and non-Hispanic adolescents. This is a similar slide showing differences in coverage and intent by social vulnerability index, income, and rural versus urban status. Something to note here is the higher proportion of unvaccinated but potentially reachable adolescents among those living in poverty and those living in rural areas. So to summarize these findings from the National Immunization Survey, nearly 5 months after the adolescent vaccine rollout, there remained unrealized intent for adolescent COVID-19 vaccinations. This unrealized intent was largest for adolescents living in poverty and living in rural areas. So therefore, it's critical for public health and clinical partners to redouble efforts for equitable access to COVID-19 vaccinations. And this could include, for example, strategies such as school-located vaccination clinics. And now I'm going to move on to talking about formulation and dosing for the Pfizer-BioNTech COVID-19 vaccine. The Pfizer-BioNTech COVID-19 vaccine for children ages 5 to 11 years is a different formulation than the formulation for persons 12 years and over. It's the same active ingredient, but a different formulation with a different buffer. The 5 to 11 year formulation comes in an orange capped and labeled vial, while that for persons 12 and older comes in a purple vial. The dose for children aged 5 to 11 is 10 micrograms, compared to 30 micrograms for persons 12 and older. The pediatric formulation also requires a different injection volume and a different amount of diluent. Please note that while they contain the same active ingredient, these products are not interchangeable, and you should not attempt to draw up a 10 microgram dose using the formulation for ages 12 and above. And I won't go through this information in detail, but the storage conditions also differ for the two formulations. For both age groups, 2 doses are given, spaced 3 weeks or 21 days apart. Currently, children ages 5 to 11 years with moderate and severe immunocompromise are not recommended to receive an additional primary dose, such as is recommended for ages 12 and above. However, ACIP and CDC will continue to evaluate data to update recommendations if needed. Similarly, booster doses are not currently recommended for anyone under 18 years of age. Children should receive the age-appropriate vaccine formulation regardless of their size or weight. As opposed to many medications, vaccine dosages, not just for COVID-19 vaccine, but for vaccines in general, are based on age and not on size or weight. And a question that we've been getting a lot relates to what you do for children who are 11 when they get their first dose and have turned 12 by the time they're due for their second dose. And the CDC recommendation is that the dosage should be based on the child's age on the day of vaccination. So if a child is 11 years old when they receive their first dose and they've turned 12 by the time they're due for their second dose, they should receive the pediatric formulation for their first dose when they're age 11, and the adolescent adult formulation for their second dose when they're 12. However, if in this situation they receive the 10 microgram dose for their second dose, it does not need to be repeated. Now I'm going to move on to talk about some considerations related to vaccine recipients. Children with underlying medical conditions may be at increased risk for severe illness from COVID-19. However, severe COVID-19 can occur in children with and without underlying medical conditions. Therefore, COVID-19 primary vaccination is recommended for everyone ages 5 years and older, regardless of underlying medical conditions. People with known SARS-CoV-2 infection should defer vaccination at least until they've recovered from the acute illness if they had symptoms, and that they've met the criteria to discontinue isolation. However, serologic testing to assess for prior infection is not recommended for the purpose of vaccine decision-making. COVID-19 primary vaccination is recommended for everyone ages 5 years and older, regardless of a history of symptomatic or asymptomatic SARS-CoV-2 infection or seropositivity. Among over 400 million individuals 12 and older that have been fully vaccinated with Pfizer-BioNTech COVID-19 vaccine in the United States, there have been no safety concerns associated with vaccination of those who had prior infection. Furthermore, while on a population level, both SARS-CoV-2 infection and COVID-19 vaccination result in some level of immunity to infection, post-infection immunity is more heterogeneous and depends on individual factors as well as severity of infection. Whereas post-vaccination immunity is more predictable, reliable, and consistent. Unfortunately, we're not yet at a place where we can reliably measure immunity to infection, as there are multiple limitations to antibody testing. While antibody tests can determine if a person was infected in the past, they cannot determine when a person was infected. Antibody tests greatly vary in their sensitivity, particularly more than 3 months after infection. And people can test positive on commercial antibody tests even after other markers of immunological response, such as neutralizing antibodies, have waned. Most importantly, at this time, there is no FDA authorized or approved test that providers or the public can use to reliably determine whether a person is protected from infection. So moving on to patient and parent counseling. In terms of side effects, patients or parents should be counseled on expected side effects of vaccination, including local reactions such as pain, swelling, or erythema at the injection site, or systemic reactions such as fever, fatigue, headache, chills, myalgias, arthralgias, and lymphadenopathy. Based on clinical trial data, children may experience fewer side effects than adolescents or young adults, and children with evidence of prior infection may actually have fewer side effects than those without evidence of prior infection. While preemptive medication prior to vaccination is not recommended, routine antipyretic or analgesic medications can be taken for the treatment of post-vaccination local or systemic reaction if medically appropriate. In terms of counseling surrounding the possible risk of myocarditis and or pericarditis have occurred rarely in some people following receipt of mRNA COVID-19 vaccines, typically within a few days following receipt of the second dose. What we do know about this risk comes from post-marketing data in adolescents and adults, in which the observed risk is highest in males 12 to 29 years of age. Importantly, the risk of myocarditis or pericarditis after receipt of an mRNA COVID-19 vaccine in adolescents and adults is lower than the risk of myocarditis associated with SARS-CoV-2 infection in adolescents and adults. FDA has authorized the Pfizer-BioNTech COVID-19 vaccine in children ages 5 to 11 years based on the determination that the benefits of COVID-19 vaccination outweigh risks in this population. People receiving mRNA COVID-19 vaccines, especially males aged less than 30 years, should be made aware of both the possibility of myocarditis or pericarditis following receipt of mRNA COVID-19 vaccines, and should seek care for symptoms of chest pain, shortness of breath, or feelings of having a fast beating, fluttering, or pounding heart. Any cases of myocarditis or pericarditis after vaccination should be reported to the Vaccine Adverse Event Reporting System, or VAERS. There are a number of resources on the CDC website to help promote pediatric vaccination, and I've provided all the links for you here. And finally, some comments on vaccine administration. Especially during the influenza season and with many children having fallen behind on routine childhood immunizations during the pandemic, it's important for vaccine providers and parents to know that COVID-19 vaccines may be administered without regard to timing of other vaccines. This includes simultaneous administration of COVID-19 vaccine and other vaccines on the same day. Both the clinical considerations website listed here and a standalone job aid provide tables with possible administration errors, as well as actions to take after an error has occurred. And then as a reminder, all of the clinical information related to COVID-19 vaccine administration can be found in the CDC interim clinical considerations for COVID-19 vaccination on the CDC website, along with a number of other clinical resources and tools, including a summary document of the clinical considerations, a pre-vaccination checklist, standing orders for administering COVID-19 vaccines, vaccine preparation and administration summaries, and other resources. And finally, I wanted to highlight what you as providers can do to promote vaccine safety. First, be sure to report adverse events following vaccination to the Vaccine Adverse Event Reporting System, or VAERS, even if you aren't sure if vaccination caused the adverse event. Second, encourage your patients to enroll in vSafe, which is a smartphone-based system that prompts vaccine recipients to complete periodic web-based health checks and also provides reminders when it's time for the second dose. Parents can enroll their children in vSafe and complete the surveys on their behalf. So in summary, vaccine policy decisions are made on a balance of known benefits and risks to the individual. Other benefits, such as prevention of transmission, greater confidence in return to school and social interactions, and risks, such as extrapolation of myocarditis risk from other ages, are also part of a broader picture. We now have experience with over 400 million doses of mRNA vaccines administered to people 12 years of age and older. Based on this experience, the benefits of vaccination outweigh the risks. And now I'm going to hand the floor over to my colleague, Chris Duggar, who's our Vaccine Distribution Administration and Partner Support Lead. So I'm going to stop screen sharing. And hand it over to Chris.
Thanks, Rachel, and good morning still, or maybe good afternoon, everybody. And thanks for having us today. I wanted to show you the milestone chart that we're using now, where we've come from and where we are today, including the pediatric age 5 to 11 rollout. And we are in week 49 of COVID vaccine distribution here in the United States. We're actually 26 days away from our 1-year anniversary of the first delivery and first administration. So we're pretty excited about that. What we want you to see is the number of doses delivered and administered. We've passed 445 million doses administered of COVID vaccines today. We see over or nearly 2 million doses of the pediatric vaccine already on the books as well. And we do hope that all of this information and this visualization supports any questions you have about safety. Again, a lot of this vaccine has been used safely in the United States. We want people to feel comfortable, especially as they bring their kids in for appointments. To date, we have made 25 million doses of the pediatric formulation available for ordering, with the latest thresholds posted yesterday, Wednesday. There's over 19 million doses ordered so far, with about 17.5 delivered, more arriving this week, and limited deliveries next week just due to the Thanksgiving holiday. So again, we want you to feel comfortable in the supply. There's plenty of doses available. We just want you to know that if you haven't ordered yet, you can with your jurisdiction, just contact them. But next week is a pretty slim delivery window, just because of the Thanksgiving holidays, and we know a lot of offices are closed Wednesday, Thursday, Friday. Going into December's 5 days a week until we get to the end of the month, we'll have holiday schedule again. There's no other big concerns. Just remember, any of the COVID vaccines that we deliver to you will include all the ancillaries necessary to administer. The pediatric kits come with 1-inch needles and 1 ml syringes. We have had pediatricians asking for 5/8, but we don't provide those. We stick with the 1-inch, and our health education team likes to say 1-inch mainly because it's an IM vaccine. They do want you to have a long enough needle to get it into the muscle. Other than that, we're here to answer questions and appreciate your time. Back to you, Miranda.
Thank you so much, Chris and Dr. Gorwitz. This has been an absolutely fabulous presentation. And when I started today, I had a full page of questions that have been submitted by our audience, and you all have done a fabulous job of answering quite a few of those questions. However, I would like to dig in, if I can, for a moment on some of the questions that weren't answered and see if you can provide some comments to the audience. To get started, a question was submitted to our Q&A asking about in reference to the formulation and dosing slide that was shown, what is meant by the additional primary dose, and is this different than the booster?
Yeah, thank you for that question. It is different. So the additional primary dose refers to an additional dose of an mRNA vaccine that is recommended beyond the first 2 doses for people that are moderately or severely immunocompromised. For Pfizer, this is down to age 12. So people 12 and above who are moderately to severely immunocompromised and who've gotten the primary mRNA vaccine series are recommended to then get an additional primary dose at least 28 days after the second dose of the primary series. In addition, those people are also eligible to receive a booster dose 6 months after the additional primary dose. But of course, there are also recommendations for booster doses among people that aren't immunocompromised. And, there's going to be an ACIP meeting tomorrow, and, some of this may be changing. But currently, the booster dose recommendations among those people who got a primary mRNA vaccine series, the recommendations are divided into sort of shoulds and may. So the shoulds should get a booster is everyone that's 65 and older, lives in a long-term care facility, or is 50 to 64 years old and has underlying medical conditions. And the may get a boosters are people 18 to 49 who have underlying medical conditions or who are at risk because of occupational or institutional exposure. For the Janssen vaccine, which is a single dose vaccine for 18 and older, everyone who got a Janssen vaccine is recommended to get a booster 2 months after their first dose, and there are no additional primary dose recommendations for the folks that got Janssen. But I just will reemphasize that currently, and this likely will change in the future, there currently aren't booster dose recommendations for anyone under 18 in terms of the additional primary dose for immunocompromised. That one recommendation does currently go down to age 12 and above.
Thank you. That's great information. Kind of shifting gears a little bit as we look to some of the studies from Pfizer and Moderna, do we know any time frame on when those studies will be completed for the under 5 age group?
Yeah, that is a popular question. We don't have a definitive timeline. Those studies are, currently underway. They're evaluating doses lower than the doses used in ages 5 and above to determine what is the lowest dose that's both, efficacious and, and the best balance between efficacy and safety, reactogenicity. Again, we don't have a firm timeline, but we anticipate that those applications will be submitted to FDA sometime in the first quarter of 2022.
And you had mentioned that the dose was lower than what was being used in the 5 to 11. Do we know what that dose is?
No, it could wind up being the same dose. It could be lower. Part of the thing that takes time is when they move down in age groups, they start looking, they look at a range of doses and, to find target the lowest dose that's still efficacious. So it's possible that it will be a lower dose. It's possible that it'll be the same dose used in 5 to 11. We don't know yet.
And then finally, I'm wondering if you can share a little bit about what successful strategies you're seeing out in the pediatric and primary care community from the patients and parents that are really kind of on the fence, those that may be reachable and those that are intending or, anticipate wanting to get the vaccine. What is the best messaging, and how is that, how would you recommend communicating that to that population?
Yeah, that's a great question. There's a whole host of resources on the CDC website that goes through strategies for talking to patients and talking to parents. I think the basic components are, first listening to a parent's concerns, so that you can respond directly to their concerns, demonstrating that you understand what their concern is, and then, offering to provide them information that would help sort of mitigate their concern about that particular risk. I'm not an expert in this area, but there are whole, strategies of, interviewing and talking to parents to help, be able to promote and reduce vaccine hesitancy.
That certainly is something I think we're seeing here in Kentucky and nationally as we try to answer and mitigate the fears that are out there, along with all of the misinformation that can be found online and in various media platforms. Chris, a question came in, and I'm not sure that you'll be able to answer this, or Dr. Gorwitz, but a question came in about the rollout of the vaccine and the partnership with some of the public school systems in terms of the pediatric vaccine. Can you talk about that logistically or delivery-wise in any way, Chris?
Sure, it varies. I guess the simplest answer is we're working directly with the jurisdictions and the pharmacy channel. They are where we put most of the inventory for ordering. The pharmacies focused first on supplying their stores that were comfortable serving, and then they're trying to direct inventory to those stores that have already enrolled or partnered up with the school in their district. A lot of the jurisdictions, as well as the county or public health institutions, already have some of these networks in place. So some of their ordering around the holidays, of course, is intended for use in school settings. But again, it was put out broadly, and the Department of Education also put out a letter. So there was a lot of awareness about this. I think the inventory and the scheduling and everything else is sort of playing catch up as they sort of figure out what's the best scenario, best timing, especially in between the Thanksgiving and the end of year holiday break.
And Chris, what about some of the other, interactions with community groups and churches and other, community civic groups that may be able to play a part in getting kids vaccinated?
Sure. I mean, we broadly support all of these efforts. A lot of it is just making the connections and scheduling the time. One of the benefits, of course, with this pediatric vaccine is it can be held in refrigerators for up to 10 weeks. So we believe that'll really help with any distal operations or satellite clinics. That's a big improvement compared to the adult formulation. There is still diluent with this Pfizer pediatric vaccine. So there is a bit of groundwork to be done once the clinic's established. We just want to make sure, whether it's the public health nurse or a local team working on that, they've got a good plan in place to receive it, store it, and then prepare it for administration, whatever they schedule, wherever they schedule. And then I guess one of the key bonuses for this formulation as well was Pfizer was approved so that this product, once you've reconstituted, it's good for 12 hours. So the previous Pfizer products are still only good for 6 hours once you've reconstituted it. The pediatric formulation only, the orange cap, is good for 12 hours. And that'll really help some of these satellite clinics. They'll be able to set up, prepare their vaccine, and they're good for 12 full hours.
I agree. I think that's great information for people to know, especially, you know, as we're looking to reach bigger groups, rural areas where we may need to have that shelf life a little bit longer. So that's wonderful. It looks like those are all the questions that I have received. I really appreciate you being with us today. You brought so much valuable information. And again, you answered so many of my questions throughout your presentation that it made it really easy for this portion of things. If anybody has any follow-up questions, where would you like them to go? Just the CDC website, or reach out to us and we can communicate with you? What would be the best option there?
I mean, it's fine if they want to reach out to you and you want to get in contact with me, that's fine.
Perfect. And actually, I just had one more question pop in, and since we just have a few minutes, I'll throw it out there to you. The question is asking about the recommendation to vaccinate those that have had COVID as soon as isolation ends. But are there days of less side effects or better immune response if we wait to give it?
Yeah, that is a really important question. So, you know, we do know that there's a benefit to, you know, that although you develop immunity following infection as well as following vaccination, there definitely have been studies that show that there's an additional benefit still to getting vaccinated even after you've been infected. In terms of the, you know, the timing between infection and getting vaccinated, that's an area where we just really don't have a lot of data. So our guidance basically, you know, says that, you know, at a minimum, you should wait until the, you know, you've fully recovered and you're out of the isolation period. If you wanted to wait, you know, I think it would be reasonable, you know, if you wanted to wait a few weeks, maybe a month, you know, that would be okay. And, you know, hopefully we'll have a better understanding, you know, over time of the, you know, or a better way to assess immunity following infection so that we could give a more definitive answer about this. But right now, you know, in general, yeah, I would say, yeah, if you've just gotten over an infection, do you need to go out the very next day and get vaccinated? You know, probably not. But I probably wouldn't wait more, you know, than a month or so.
Thank you for taking the time to answer that final question. And thank you again for being with us. Again, just a wealth of information, and we so appreciate all of the efforts of you all out there on the front lines, passing on and continuing this great communication. And thank you again for being with us today. And thank you to all of you out there as well.
Thanks for inviting us.